Thank you very much for this nice introduction. I will try to cover the whole field. So actually, I will try to talk about depression and somatic comorbidity. That means we know now that a lot of patients suffering from different kinds of somatic diseases like cardiovascular disease or like cancer, they also suffer from depression. But it is also the other way around, saying that depression is an independent risk factor for cardiovascular disease. That's quite well known, and we know that already for about 30 years. So there's a very tight connection between somatic diseases and depression. And actually, I would say depression is a systemic disease, and not only something which occurs in the brain, but it's also affecting the whole body, at least for a group of patients. So that's the topic I'm talking about. But I will start about some general remarks about depression, let's say some issues about epidemiological facts of depression, also of the cause of disorder, and I will talk about the clinical appearance. How do the patient look like, and how is he suffering about? What are the main problems for the patient, him or herself? And then, of course, the main thing will be the connection between depression and somatic morbidity. And I think one possible link, or let's say one important link between those two fields is immunology. So I will focus on certain parts of immunology, especially inflammatory activities, which can explain some of these connections between depression and somatic morbidity. And at the end of my talk, I will also focus on some therapeutic aspects and some future aspects. So that will be the program. So affective disorders actually, of course, are disorders which are affecting our feelings and our emotions. Let's say people are really suffering from sadness, from guilt feeling also, especially also from the feeling not experience joy anymore. But also some people are also having other emotions like being more aggressive, feeling tightness. So they're really suffering in this emotional field, but also in this cognitive field, not being able to concentrate, not being able to read a book anymore, not being able to follow a talk or to talk for a longer time with somebody else. So they really feel not being able as they have been before. So they feel deficits in very daily living situations. And of course, affective disorders, and that's really important, are also disorders which can end lately. So that means suicide is a very big problem for these people. So the other way around, about 70 to 80% of patients committing suicide, when you look at their histories, you will find a history of depression, probably in many, many cases. So that's one part for the increased mortality, but there's also another explanation for increased mortality, and that's the connection to somatic diseases, especially chronic somatic diseases, as I'm going to talk about. Another aspect is that affective disorders, especially depression, is something which really is a challenge also for the mental health system. It really costs a lot, and it really, it's getting more and more important also as a reason for sick leave or for early retirement. So it's becoming a greater problem the last years in these respects. When we look at the lifetime risk, we know that in the general population it's up to 20%. Females are more often affected. And especially these patients are found in the general practitioner, in the family doctors, but of course also in the general hospital. And of course it's also something which is very often connected to other psychiatric diseases. So depression is also something which occurs with other psychiatric diseases like drug addiction, alcohol dependence, or anxiety disorders. So it's something which is not only a comorbidity in somatic diseases, but also in psychiatric diseases. And it's also true for depression. If you have an early diagnosis and the early treatment, the outcome is much better. So that's very important. And you have the influence for the mortality, as I already said, and for the somatic diseases which can develop. But on the other hand, it's also important to realize that depression in many, many cases is really coming back to the normal level of living before. So many important people were suffering for depression, although they were able to achieve their life aims, their life goals, and suffering for long periods of depression, but being able to fulfill great lives. When we talk about the cause of depression, we have different causes. Saying there's one cause which is having one depressed episode, and after that it's reaching again the state before with some small decline again, but not really reaching a depressive episode again. But there's also the recurrent situations for several episodes, and also hypomanic or manic episodes which might be coming up. But for the most difficult situations for the patients themselves are these chronic causes, where they're not reaching the level they had before the start of the disease. So that's a very difficult situation when you really don't reach the level as you had it before. When we talk about depression, as I already said, it's especially affecting our feelings and emotions. The feeling of really being sad, it's something different of having a sad experience or losing somebody who is near to yourself. This sadness is connected with this inner emptiness, not feeling attracted anymore to somebody. People are always telling the most difficult situation is that they don't have a feeling for their partner anymore, for their children anymore. They are really inside that. Another person I'm always thinking, coming up in my mind when I'm talking about feeling depression, she always said, the days like it is today with sunny day, sunshine, it's very difficult to bear, because it's much better to have it dark, not to see that others are loving, not to see that there's outside a good situation, and she can't imagine that she ever had also this good situation and being part of this good situation. Now she really feels departed of this good situation of life. She can't have the remembering that there was something different before. Then, of course, with this situation, there's hopelessness. In many situations, also feeling of guilt, not being able to do as I did before for my family, for my work situation, but also, of course, doing the social withdrawal. As I can't feel attracted to somebody else, I don't get in contact. I'm getting away and I'm hiding myself. The lack of energy is also a great problem. It starts in the morning, not being able to rise from bed, not being able to do the daily situation at home, starting with my personal hygiene, and also like things like cooking or daily situations are not able for patients with suffering from severe depression. Sleep problems is a very common situation. It's also sometimes the first symptom, and it really the patients are always have the feeling they never get enough sleep, and they can't recover anymore. Then they also have significant changes in appetite. They're not feeling interested in eating anymore. They lose weight. But there are also some forms of depression where they eat much more and gain weight. But most of people have really the problems of losing weight. Then in this connection, it's very easily to understand that there's poor self-esteem with pessimistic future perspectives. And of course, with all this coming up, there are some of them are ending up in the thoughts, it's better not living anymore. I'm only a problem for my family. I'm only a problem for my partner. And we have also somatic symptoms. These people often complain about dizziness, about pressure on the chest, different kinds of pains, and also digestive problems. So the main symptoms, of course, are depressed mood, lack of interest. I'm not interested in anything. I'm unable to enjoy anything. And of course, this permanent exhaustion, so lack of energy. Everything is a great difficulty to do. What people often say is, I really lost my self-esteem. I lost all my humor. I can't feel attached to my family, to my partner. Everything makes me to feel exhausted. Or also, I can't experience joy anymore. I can't concentrate anymore. I feel empty inside. But we also have a special situation. In the last years, we were often talking about the situation of depressed men in a advanced age, like let's say 50, 60, something like that, having a different clinical experience with more tension, with more dysphoric mood, with more aggressive behavior, with more arguing in the family. Sometimes the first impression is not suffering from depression, but something changed. Also the person himself says something has changed, but more the family, the wives may tell you about there is something going on, there's something different now, and sometimes it develops quite slowly. So that's a different form of depression. When we talk about really importance of early diagnostic situation, we have some screening areas. This experience of joy is something we can ask for. Then also regular activities, this feeling of emptiness inside. But also this sleeping, as I already mentioned before, is a very important marker for the development of depression. Not being socialized anymore, not being able to concentrate, a great increase of different kinds of anxieties and fears also. And also the situation of it would be better not being here anymore. Yeah, the risk for the development of a depressive episode increases in situations where already has been a depressive episode before, or also there's a positive family history. Also suicide attempts, which might hide or have been hidden a depressive episode before, are risk factors. Then somatic comorbidity, as I already said. As more somatic diseases you have, especially chronic diseases, you have a greater risk to develop also a depressive symptomatology. Then, as a part of comorbidity of other psychiatric diseases, especially addiction diseases, addiction disorders. Then, of course, it's connected always with negative, not always, but it can be connected with negative life events, especially if there's no good possibility to cope with these life events, especially also if there's a lack of social support in these situations. And what we really know, which is getting more and more important in our field of research, is the influence of early life trauma for the development of depression later in adult life. So that's something which is really important risk factor also. So, of course, genetics also play a role in affective and especially also in depressive disorders, but we know they only explain a part of the development of the disorder. Then, of course, neurotransmitter changes are the basis, or at least the basis we are going to treat by antidepressants. And of course, we know that there is a great problem in adaptation to stress. Chronic stress situations like not being able to cope with negative life events, they have a great impact on the development of depression. Then changes in chronobiology, they are also important. And some typical personality markers, some typical personality traits are more often seen in depressed patients. And as I already said, early life trauma experiences, and also behaviors, maladaptive behaviors like learned helplessness, always being helped by somebody. Because I have experienced, let's say, a trauma in my early adulthood, and had the experience that I'm helped by somebody else, that I really get more attention by this experience, and I adapt this behavior more and more also for other situations. And this, of course, is not a good situation and could be the basis also to develop a depressed situation. Then talking about somatic comorbidities. As I already said, the risk is really higher as soon as there is especially chronic somatic disease, but also the other way around. And we know that the depressive disorder have a negative impact in the course of the somatic disease. So the morbidity increases, but also the mortality. Just to give you an overview, what are the prevalence rates of depression, especially in cardiovascular disease, up to 30%, diabetes also up to 30%, and cancer. And that's not the advanced situation of cancer, that's the early situation of cancer. But of course, also diseases which are really affecting the brain are seen with a high incidence of depression as comorbidity. In Parkinson's disease, for example. Sometimes in Parkinson's disease, depression is one of the first signs, like being seen before other symptoms. Also in Alzheimer's disease, or also in chronic pain disorders. Of course, that's very often connected with depression. And I want to stress something. It's not only the situation that I'm, of course, not in a good situation when I have a chronic somatic disease and I have a depression as a reaction. It's really an additional connection where I'm going to focus on. So, as I already said, about this tight connection between cardiovascular disease and depression, we know already for a long time that patients with depression and cardiovascular disease have a 2 to 3 fold higher risk to develop a heart attack. Also, the mortality is increased in this situation, but also depression is an independent risk factor for developing cardiovascular disease. The same connection, nearly the same connection, is also seen for patients with diabetes. So we have also here the both side fold connection, and as I show you here in this picture, it's a follow-up study about 10,000 persons, and some of them, 700, have a diabetes. And you see here the survival function of patients of the non-diabetic group, depressed and non-depressed. There's not a great difference. But when you look at the diabetic cohort, then you find here the influence of depression with a significant difference in the survival in the group of having diabetes and depression at the same time. About cancer, there's a very interesting paper already published in 2008 by Arthur Miller. And he explained the situation between cancer and behavioral alterations, especially depression. And what he tried to do here in this paper was that he said, okay, the tumor itself, but also the therapy, but also the psychological stress situation cancer patients are suffering from, they all have the situation that you have an activated inflammatory response system. Activated inflammatory response system means that pro-inflammatory cytokines, especially the cytokines or the adhesion molecules, acute phase reactions, they are activated and they have an influence and impact on sleep-wake cycle, but also especially in the neuroendocrine system with the HPA axis, with the glucocorticoid axis. And these have effects, of course, on the CNS, on the neurotransmitters, on the growth factors, and resulting in the behavioral alterations like depression, fatigue, impaired sleep, or cognitive dysfunctions. So talking about these connections between somatic diseases and depression, we know that there are biological mechanisms known to be changed in depression, especially this HPA axis, the sympathetic nervous system, but also immunological changes. As I already said, this inflammatory responsive system is activated, and these situations can result in having a clinical implications in cardiovascular diseases, but also other inflammatory diseases. And when we look at this situation, what are the reasons for chronic inflammatory processes? Not high inflammatory processes. These are low-grade processes. It could be, as I said already, early life stress, trauma, chronic psychosocial stress, as we have it in chronic conflict situations, but also obesity, diminished sleep. These are all factors which are resulting in chronic low-grade inflammatory processes. And these chronic low-grade inflammatory processes can be the basis of other chronic somatic diseases like cardiovascular disease, like depression, like cancer or diabetes. So we have these chronic inflammatory processes as basis in both directions for somatic diseases and also for the depressive disorders. Taking together, we know that for depression we have a number of different hypotheses which might be a reason or might be basis of depressive symptoms, especially monoaminergic system, the serotonin being diminished, not being available, also the other systems like the glutamatergic system, neurotrophic factors being influenced, especially HPA axis having deficits, but also the inflammatory system especially being affected in this situation. And in this inflammatory system I want to focus here. We have these inflammatory cytokines which are influenced by chronic somatic disorders, but also by external stress situations like chronic conflict situations, negative life events. And what you see here is that these cytokines affect different parts which are resulting in neuroplasticity changes or changes in neuroendocrine pathways, the HPA axis, or changing in neurotransmitters, especially the tryptophan-phenylalanine pathway or also the phenylalanine and tyrosine pathway. And these two pathways, the tryptophan and the phenylalanine pathway, I want to focus on. Tryptophan, as you already know, is the step before serotonin. And when we have an immune activation on this macrophage axis in the immune system, monocyte macrophage axis, we have an activation of the enzymes here. And with these enzymes, we get an activated metabolism of tryptophan. And then tryptophan is not available for being then developed to serotonin. The same is true for phenylalanine and being developed for tyrosine. So those both pathways are really influenced by immune activation, by inflammatory immune activation processes, so that this metabolism is turned on and the tryptophan and phenylalanine are metabolized and not being able for available for serotonin, especially in the tryptophan synthesization. When we talk about inflammatory processes, of course we all think of CRP. CRP as a marker for inflammatory processes. We know, and we have a number of studies on that CRP is changed in a group of our patients suffering from depression. CRP, but also other cytokines like IL-1 or IL-6, all reflecting the activated inflammatory response system. But we have it in both directions. We have the situation that depression is causing then, the depression is coming before the inflammatory increase of CRP, but also that CRP is predicting depression later on in life. So we have really the both-way situation of influence. This is just to show you that there are a number of markers already studied in depression showing that they are increased, especially always this inflammatory response system. And we also did a study in this field, and I will just mention it very shortly. We looked at patients with breast cancer and patients suffering from depression and a group of healthy controls. And what we did, we looked at these both pathways, tryptophan, yes? Yeah, there are some, there are already studies on that where they are used as the hippocampus. We know that there is an influence on the area of the hippocampus where inflammatory cytokines decrease the activity there. In the prefrontal cortex, we also have an influence of inflammatory cytokines. And of course, a very interesting field is always the influence on microglia. We now are able to have the picture of activated microglia, and there are already some studies showing that in a part of patients with depression, we have an activated microglia situation. Right, we will talk about that a little bit, yeah, okay. So, and what we did is we looked at these both pathways, and what we found is that the patients with depression had an immune activation, and these pathways were both changed. Especially the phenylalanine tyrosine pathway was more influenced by depression. Quinine tryptophan pathway was more influenced by anxiety, but both symptoms were much more pregnant, much more present when somatic disease and depression both were present. So that is an additional effect in this situation. And of course, when we have this situation that the phenylalanine tyrosine is more affected in depressed patients suffering from cancer, there can be also the discussion that they might be better for them to give them not SSRIs, but noradrenergic drugs. So what I just wanted to show you is that the neurotransmitter situation is connected to the immunological situation, especially the inflammatory response activation. So there's a very tight connection between these systems, which can explain to part of the comorbidity between depression and somatic diseases. So talking a few words about the therapy also, we know that it's very important for the family that the family are involved in therapeutic options and therapeutic processes. It's very important that you have a very tight relationship to your patient, that you really explain to him or her what's going on, not only in the psychopharmacological treatment, but especially, of course, in the psychotherapeutic treatment. And it's very important to do this evaluation of therapeutic processes, especially if you look at psychopharmacological treatment. A part of our depressed patients are older patients, and they have several admittance to the hospital. And what I am always realizing is every stay in the hospital results in another drug. And after the third or fourth stay in the hospital, they come up with 5, 6, 7 different drugs, not only psychopharmacological drugs, all the way. And it's difficult for them to take all this. So it's really necessary to evaluate the drugs they are taking, not only psychopharmacological medication, but in total, also the psychopharmacological medication. Some of them have 2 antidepressants and a benzodiazepine and an antipsychotic maybe. So it's sometimes really terrible what they are taking, and nobody is evaluating this situation. So treatment options, as I already said, are of course antidepressant drugs. Of course, psychotherapy. We do have a lot of studies about psychotherapy, not only CBT, cognitive behavioral therapy, but also different psychodynamic therapies, and they do really work. So that it's not something which is not effective. They are really good and effective. Exercise. A very systematic sport activity is really helping against depression. It's very well studied. There are very nice results about that. But of course, if you're suffering from a severe depression, it's difficult to do it. It's just not possible for the patient. But for mild forms, for moderate forms, it's really good working. Light therapy, also something which is helpful for a part of our patients, but only a part, especially for them with this suffering in the winter time with this diminished light situation. Sleep deprivation is especially helpful as additional therapy to improve the activity, to get up in the morning, and to improve the effect of antidepressants. ECT, something which is still used, and also used especially in situations where antidepressants are not successful. So if you have the situation that you have the third antidepressant drug or the third long-time psychotherapy situation and the patient is still not improving, then it's of course okay to think also of ECT. TMS is something which is more experimental. I don't want to talk about that very much, and also the situation about vagus nerve stimulation. Yeah, there of course are guidelines, and for the psychopharmacological treatment, antidepressants are the most important, but also mood stabilizer to prohibit another episode, and antipsychotics sometimes also to use in the time between the depressive episodes. Benzodiazepines are necessary, especially in the beginning when there is a very severe situation or where the sleep is disturbed very much. So you need a benzodiazepine, especially to overcome the lag between the time the antidepressants need to work. Yeah, I think that's already talking about that. So future aspects, what we are doing with this pathway studies. What we really want to do is to find biomarkers as diagnostic tools in these pathways, but also to find biomarkers for more personalized medicine. As I said before, it seems that in patients with cancer that it might be better to use not an SSRI, but an SNRI. But also for other treatment options in this inflammatory context are important. We know that cytokines like TNF-alpha antagonists are now in the first studies on that. Also, cytokine signaling pathways inhibitors like COX inhibitors or metabolic pathway inhibitors like IDO, the enzymatic inhibitor. They are all now in studies, and some of them are quite interesting first results. Something which is also, of course, anti-inflammatory is omega-3 fatty acids. Then, of course, different kinds of nutrition and exercise, I already said. Relaxation is also something which is quite interesting in this field, talking about the inflammatory system being influenced by chronic stress. So you have a possibility to influence the system also by relaxation. Yeah, I think that's the last slide. It gives a very nice overview. It was came just out very recently about the last 20 years about depression and inflammation. So if you're really interested in that, it gives you a nice summary in that field. So thank you very much for your attention, and if there's some questions.